Hello and welcome to today's webinar, Using Health System and Provider Culture Change to Address the Impact of Racism and Bias on Patient Outcomes, made possible with support from Genentech, a member of the Roche Group. Before I get started, I'd like to quickly go over a few logistics. To eliminate background noise, audio lines are muted during today's event. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. A brief online evaluation will pop up on your screen following today's event. Your feedback is very important to us, and we hope that you'll take a moment to complete this survey. I will now turn the webinar over to Shilpa Patel, Associate Director for Health Equity at the Center for Healthcare Strategies.
Thanks so much, Travis. Hi, everybody. My name is Shilpa Patel, and it is my honor to officially welcome you all to our webinar on using health system and provider culture change to address the impact of racism and bias on patient outcomes. So given the topic of this webinar and the work that we all know go into this, we are going to do things a little differently for this webinar. So instead of a PowerPoint-heavy presentation style format, we instead invite you into a space of reflection and thinking, which I can attest to are often very limited in my day-to-day activities. So we're really trying to create that space for you all here today. We've assembled some great expertise on this webinar to facilitate this process of reflection and thinking, but have also incorporated opportunities for you all to pause and reflect on what you would like to get out of this conversation, as well as what you'll be taking away from it. So to start us off, I invite you all to respond in the chat to our first question to you. So as you enter this conversation and this topic, what are you thinking? What are you feeling? And if you could respond to that in the chat, that would be great. And I'll put that question just so you have it too. And as you respond to that question, I want to introduce our colleague, Elizabeth Hawkins, the Principal Manager of Corporate and Employee Giving at Genentech, to also provide some welcome comments. Elizabeth, over to you.
Thank you so much, Shilpa, and to the CHCS team. I really appreciate it. And I will keep my comments very short because I do not want to get in the way of this dialogue. As we dive in here, I wanted to share two things with you. First, a little bit about why Genentech is so excited about this work and how we intend to continue to support this space going forward. And then a little bit about what I've learned from the wonderful people you're about to speak with. The first is the CARDO project, which Shilpa and Danica will speak to shortly, is one of the areas that we have been super excited to invest in over the last year or so. Genentech is deeply committed to giving in a few areas that address the root causes of health inequities. And we do this through a number of ways. The first is supporting a deeper understanding of accountability to action towards addressing systemic racism in clinical trial research and care delivery. We want to support initiatives, people, institutions, organizations that are shifting power to community, that are bridging clinical community partnerships, and that are figuring out the research landscape to really make clinical trials and healthcare delivery more equitable. The second big priority for Genentech is creating a scientific and medical research community that can respond to the forces of racism and deliver empathic and high quality care. And so for us, this means both investing in the STEM pipeline as well as ongoing training and support. And so much of what this work that you will hear about today supports those two initiatives. I would say this is all in service of supporting a healthcare system that ultimately will be hopefully more healing, which is a phrase that I take from Dr. Epstein very liberally. So those are kind of two big priority areas for Genentech. For those of you on the line who are seeking funding or are funders, please reach out. I'm very available on LinkedIn, and I'll drop my email into the chat as well. Would love to build community with more of you going forward. And then the second thing I wanted to share with you all is a deep moment of gratitude for the panelists that you're about to speak with, who I've had the pleasure of learning from and learning alongside for the last several years. For Danica, I think I've learned so much from you about the progress being in the process. The CARDO work that we've supported you all to do, you have continuously stopped, assessed, met people where they were, but then continued to push them in their anti-racism journeys. And I deeply appreciate you for that work and the leadership and the voice that you bring to that. Dr. Crawford, how to use my privilege, my power, my whiteness for good, how to disclose, which I assume you'll probably get to at some point in this dialogue. I continue to learn from you, and I want to emulate the power that you bring to this work. And then Dr. Epstein, the power of listening. So thank you for listening to us, to listening to so many individuals and organizations in this work. We all deeply appreciate you giving us that space and time. So I'll stop there. I thank you all. I'll put my email in the chat. Please don't hesitate to reach out, and I'll turn it back over to Shilpa.
Thanks so much, Elizabeth. And I really appreciate the honesty in the chat that I'm seeing. The responses come in about curiosity, openness, excitement, and eagerness to move the work forward, given the need that was made even more transparent during COVID. But also a sense of frustration, though. We need to continue having this conversation over and over again, but at least an openness to continue that dialogue, which we'll hope to achieve and kind of further as part of this webinar as well. So next slide, please. Now, in an effort for you to get to know us, we wanted to provide some information on our organization. Center for Healthcare Strategies, or CHCS, is a nonprofit based in New Jersey that works with stakeholders nationally to strengthen healthcare services to ensure better and more equitable outcomes, particularly for children and adults served by Medicaid. Since 1995, we've worked in every state in the nation. We partner with state and federal agencies, health plans, providers, community-based organizations, and members to make healthcare work better for people who face serious barriers to well-being. We at CHCS work to advance more effective models for care delivery, more efficient policy and program design, and across all our work, we focus on more equitable care and opportunities to address the obstacles that stand in the way of health equity and for people facing the greatest disparities. Next slide, please. So as Elizabeth noted, we have an amazing set of panelists, and I'm excited to get to their conversation. I'm only going to give a brief introduction here, as each panelist will introduce themselves later. So we have Dr. Dana Crawford, scholar in residence at the Columbia University Zuckerman Institute, Dr. Ken Epstein from Prep for Change Consulting, and CHCS's own Danica Richards, program officer. Next slide, please. So throughout the course of the webinar, we tried to develop a more intentional space where we can discuss the nuances of this very important topic. I'll give some overview of the project that sparked the webinar topic, but plan to spend the bulk of the next hour or so in conversation with the panelists and with you all today. Next slide. Okay, so just as I noted, the next few slides will go through the project that Dr. Crawford, Danica, and I work on together, co-creating solutions to address racism and disparities in oncology. Next slide, please. The project brings together health systems and community partners in what we internally call an inside-outside strategy. The partnerships of health systems and community-based organizations or community members come together to pilot new interventions at the community level that address racism and reduce disparities. In parallel, though, they work together to acknowledge and address the institutional racism and bias that has been maintained and perpetuated inequities in oncology-related care and outcomes for communities of color. Next slide, please. So we are extremely fortunate to work with 3 amazing partnerships around the country in an 18-month learning collaborative to advance the 3 objectives noted in the previous slide. These sites are the Chrysalis Initiative and Cooper Health at MD Anderson Cancer Center in Philadelphia and Camden, New Jersey, Sierra Sisters and Fred Hutchinson Cancer Research Center in Seattle, Washington, and Jefferson County Faith-Based Alliance for the Advancement of Health Equity and O'Neill Comprehensive Cancer Center at the University of Alabama at Birmingham. Next slide, please. So the topic of the webinar actually came out of a technical assistance or TA request from one of our sites. During the course of one of our calls, an individual had discussed how they had done some work at the individual level, like maybe all of us have, to reduce disparities, especially in oncology. But then they had asked, how do you actually create culture change at the provider and health system level? And then how do you use or leverage that culture change to more explicitly address the impact of racism and bias on patient outcomes? And we thought, what a great, important, and immensely complex question. So we wanted to unpack that question, specifically around these 3 objective areas here, which was also informed by the project throughout the course of the webinar. And with that, it is my honor to turn it over to my wonderful colleague and partner in this project, Danica Richards. Danica, over to you.
Hi, everyone. My name is Danica Richards, and this is my disclosure slide. And the reason we do disclosure slides is because we want to be honest and authentic about how we're coming to these conversations. So my pronouns are she, her. I am African American from the Black Belt, which is the Southern United States. I am a cis woman, and I am both the panelist and the project manager for this project. Now I'm going to hand it over to Dr. Ken Epstein.
Hello, everybody. I didn't write disclosure. I wrote the mirror and the landscape because for me, what I'm disclosing is that I need to look in the mirror before I look at the landscape. And if I don't look in the mirror, my actions will be responsive, not reflective. So when I look in the mirror, some of the things I see is that I'm Ken, he, him, and his. I'm white, of Eastern European descent. I'm Jewish. I'm retired from leadership, which I did in the public sector for many years. I'm the middle generation of 3 generations of social work. Go Hannah, my daughter, just got licensed. Unabashed belief in the power of relationships, and I'm a long distance aging runner. All of these things and many more of my identities will come forward in everything I say today. And so from that bias, this is what I'm disclosing. I have no financial disclosures.
Thank you, Ken. So I'm Dana, and I disclose that I have no financial disclosures, but I come to this conversation as a Black woman, and those identities honoring intersectionality, and that I can't parse them out. I also come to this conversation today as what I identify as a wounded healer, a person that has first-handed experience of trauma, of hurt, of attempts to heal large systems, relationships, and individuals. And I come to this conversation with some COVID years behind me. And so I also have a bit of skepticism about the ways that we're framing and talking about trauma-informed care, trauma-informed care systems, trauma-informed systems, and the way that anti-racism is really positioned in the conversation. And so one of the biggest tools that I have found in both perpetuating racism and also not allowing people space to heal is never giving people enough time to think. Keeping people very busy often leaves no room for healing, and we're running after change rather than sitting, reflecting, looking at the landscape, spending time in the mirror, being accountable, and thinking about who we are in the role of which policies get rolled out. And so our hope today wasn't just to speak to you, it's a conversation with us. And we hope that we can create more of a collective and a circle-way conversation as much as you can on a webinar and Zoom. I own that. And so we're going to do 2 things at once. One, talk about this thing that we're all experiencing, witnessing, and hoping for change. And then we're also going to model some ways that maybe we can do that change. And so the first thing that we're going to do, well, the first thing we did was disclosure, but the next thing that we're going to do is invite you to take some time to be here. And I know you're physically here, presenteeism is a real thing. We're going to invite you to emotionally be here, psychologically be here, I dare say spiritually be here. And so next slide, what we're offering is just 1 minute of mindfulness. Listen to the music, watch the video, do whatever you need to do in this next minute, so perhaps you could be here for the rest of the minutes we have together. Thank you. You can push play. So for some of you, that minute might have felt very, very long. And to me, that's an invitation to possibly explore more mindfulness, to give yourself more time to be where you are. If that minute felt way too short, it may also be an invitation to create more of these spaces. So if it felt too long, maybe you need more experience. If it felt too short, maybe you need more time. Thank you for engaging in this way with us, and welcome. All right, so am I just kicking us off and starting off with our first question? Now I got in my mindfulness and it felt like a little bit of a rush to just go right into words. First, I just want to say, as I disclosed, I had skepticism coming into this space, and I can't think of another group of people that can hold and honor that skepticism and the questioning and the wondering than the two of you. And so it is just such a privilege I literally said, these are like the only two people in the world right now I want to talk about this with. So thank you. And so I started us off with this question. Cultural change is difficult and slow moving. What are the complementary changes at the organization, policy, and program level that can support cultural change? What expectations should be set up front before embarking on this work?
Well, Dana, I want to just ditto what you say. What a nice thing to be with you and Danica. When you said before about reflective space, it really triggered me to think about that if we wanted to create organizations that weren't going to change, let's say we just went about, like the three of us said, what's the first thing we should do? It's not going to change. Well, the first thing I would do is fill up everybody's time so they can't think. Now, not for any of the people on this call, I imagine that's not happening to any of you, but I know that from everybody I speak to, we are more busy working with less resources than ever before. And so, if we want to change reactive places, because we work in reactive places, that's the culture, there has to be reflective space. And reflective space actually is quite revolutionary. So I just appreciated you saying that even that minute was both not long enough and too short for me. So I did want to say something about culture. I actually woke up in the middle of the night thinking about this, which I shouldn't have done. But the first part of the question is culture change is difficult and slow moving. And I want to say what culture we're talking about changing. Because white supremacy, the culture of white supremacy, is a culture of taking away people's culture, taking away people's experiences, and either making it invisible or voiceless or unavailable. And what we're talking, so I was up thinking about, culture change is not difficult and slow moving. Culture change is actually about respecting the cultures that are part of our organizations so that we can change the culture of our organization. And it's slow and difficult because our organizations are built upon a set of principles and practices that have been practiced over many, many years that embed and embody racism, and embed and embody inequities, and embed and embody practices that are not healthful or wellness for our employees or folks in it. So your question, what's the first thing we need to do? I like to think about 4 R's. The first thing we need to do is we need to recognize, because what we don't recognize, what we don't see, we can't fix. And we're very much in the business of fixing. Oh, we'll just hire, we'll do this, we'll do that, we'll fix it. It'll happen overnight. But if we don't recognize the ways in which our organizations and our bureaucracies are built, not because of the people in them, not because of the intention, but the impact is that our bureaucracies are inhumane. and that it takes intentional steps to build humanity into our organizations. So the first R is recognition, and recognition is about acknowledging that we're an exhausted, depleted, grieving, rageful workforce right now that's been under-resourced for a long time, acknowledging that that's impact Black and brown people more than others, certainly more than me with my privilege. The second R is repair. We need to actually not only recognize and acknowledge, but we need to understand that ruptures have happened. And part of the healing process is we need to have repair built into our organizations, not into HR, into discipline, or into it has to actually be public and part of my supervision, part of my practice to expect that I will create ruptures, and ruptures are historical and embedded and structural, and that we need to actually heal those structures because people are hurting and unwell. And the third R is reconcile, that we have to go and reconcile those repairs with our policies and procedures, and we have to look at them and change that culture that's embedded in our policies and procedures. And it doesn't mean just a new policy. It means looking at the way we do work every day, because sometimes we have the right policy and the wrong way of doing it. And then we blame people, the practitioners or other people, for doing it that way, when in fact it's embedded into the way. So we have to reconcile. And the last one is really, we need to resist. This is about resistance. We need to resist the tendency to move back to the status quo. So when I think about those two things, it has to do with two main ideas that I have. One is we need to invest. We have to invest in a relational set of principles that are built, Dana, on what you said, that have to do with time and reflection. A set of principles that were adopted are relational, that aren't based on efficiencies, productivities, and deliverables, all language we took from the for-profit sector, all important but not sufficient, but are built on relational healing that has to do with our field of being a healing profession. So we have to invest at the leadership level in a set of principles that are relational and measure those principles in our organizations. And then we have to divest from our practices and principles that are embedded in trauma, in racism, and inequity. And we have to divest from that culture. And that's why it's slow, but actually I'd rather think it's generational.
Thank you so much for that, Ken. Danica, thoughts?
Yeah, that was amazing, Ken. I think I wanted to add a little bit more about the interpersonal aspect of this, because, right, culture change is micro and macro. And so one of the things that I have observed both throughout this project and also in my other work at CHCS is just being able to recognize when you are embarking on this culture change, or whatever we want to call it, it's being able to recognize the difference between resistance to change and resistance to the change. Mm-hmm. And this is an important distinction because the first one is a natural and human reaction to major systems change, and you can work with that. The second, however, means that the people, the entity, the institution, whatever, is not on board with what you are proposing. And there might be a misalignment of values there. And that's something that's very important to know when you are embarking on this change. And this has been one of the major things that some of our pilot sites have been working on. And again, you have to identify this at the get-go and at which level you'd like to make the culture change at, and which level you feel like you can make that culture change at. Keeping in mind, you know, we have centuries of structural racism, and some of these institutions, they're actually that old as well. Like, they're as old as structural racism. And so how do you, as one person, one group, change things? Well, you, one person, doesn't. This initiative has been really focused on what the inside-outside approach looks like, because for this level of change, you have to be working with and in the community, in addition to having agitators inside the institution. And so it's not either or, it's generally both. And so for our pilot sites that have been working with the community, they're working with the community to learn more about how the community has experienced racism while seeking cancer care. We're also saying, well, what can be done institutionally in parallel to really make some real change in that case?
I love that, bringing it micro and macro. Thank you for that, Danica. And I'm loving the chat for both of you. I'm seeing some amens, literally. Yes, I need the recordings. So thank you for those responses.
So I think I'm actually up now to ask to ask a question. So I think I'm going to ask this question to you, Dr. Crawford. So given there is overlap between trauma-informed care and anti-racism work, where might there be opportunities to impact provider culture? Additionally, what should well-intended health systems and providers be aware of when introducing trauma-informed care frameworks to their patients and communities? Is there a way in which harm can be avoided?
Oh, so I think, starting with that first part about the opportunities to impact provider culture, I have to go back a bit because what I've seen is this trend with the most recent cultural consciousness wave since 2020 to really call out systemic, institutional, organizational racism, prejudice, and bias. Like, we need to change policies, practices, and procedures. But what that often does is it gives people the opportunity to point to a source over there rather than look internally. And so in the same way that this provider sitting in an exam room, this CEO, CFO sitting in a boardroom are people with power, they're also people with histories. They're also people who have navigated a world as individuals, as babies, that then became people that have power. And so I think the biggest area of impacting provider culture is to actually engage on a human level. It is bringing more of the humanity in it. It's talking very explicitly and clearly about the ways that racism is taught, what the root cause of racism is. And I theorize that it is very much anchored in resource distribution, how to get resources, how to identify the resources, who gets the resources, who replicates the resources, who distributes the resources. And that fear of losing resources gets activated. And so when we're talking about changing, modifying, reducing cultures of racism, prejudice, and bias, we can't do that without acknowledging the hurt in that individual. And so you can ask, your doctor to, not engage in these practices and, be anti-racist. But until there is an internal process of work, a building of actual skills, it's going to be really challenging to be able to change an entire system of people. So I think the first part is creating a space and the time for people to engage authentically in the ways that racism, prejudice, and bias have shown up. And historically, many of us have never had a chance to have these conversations. Literally right now we see schools that are banning books. And so the next generation isn't going to be more skilled at having tender conversations. They're going to have less skills. And many of us never had these conversations. And depending on the year that you were born, you were taught to be colorblind. And so we are coming to this space with wonderful clinical expertise, professional expertise, great degrees, and no skills related to reducing culture. So I think skill-oriented training is also a crucial piece. In terms of being willing or trying to do less harm, I'm going to say something really provocative that's going to be really hard, and I don't know if there's any other way. We actually are going to have to value human life more than we value profit. And I don't know if we've even begun to be really honest about the ways in which we're willing to sacrifice people for profit, for the system to continue to run. And I think until that area is addressed, we are at great risk of furthering harm. That's literally what the point of enslavement was, right? Profit. And we're going to have to change that. And I don't know if many systems are willing to go there. I don't know. Ken, what do you think?
I think I agree. And, the chat is just blowing up. So I was looking at the chat as you were talking, and there's a dialogue in the chat that I just have to comment on. I want to get back to the time issue, because as I work with the healthcare profession, and when I was in, bureaucracies for many years, I want to get back that there isn't time. And so people say, how can we do this without time? And I would say, back to what do leaders need to do is think about how time is privileged in organizations, because there are people with time. And there are people without time. And I think to think about your organization, if you wanted to interrogate an organization, you would want to interrogate who is given time and who isn't given time. And that gets to an investment. Like if you invest your organization, if you even think about, you do an audit of your organization and think about how much time and money is spent on compliance and risk mitigation and legal kinds of things and consent, all of those kinds of things, all important, but how much the muscle around relational healing and what it takes to be a healing organization is not supported. So having one diversity officer and somebody who's volunteering to work on trauma-informed care is actually harmful. So I think if I want to translate, Dana, what you were saying, it's actually harmful to underinvest in what your principle is and then put out emails saying, oh, we're an anti-racist or we're a trauma-informed organization. Because I will say about trauma-informed is a lot of organizations are saying they're trauma-informed, and I think you cannot be trauma-informed unless you're anti-racist. But you can be anti-racist and must be anti-racist, and you are by proxy trauma-informed. Because to approach anti-racism in your organization, you need to look at the way you're inducing trauma into your organization unequally, and you're looking at relationships and relational healing. So I just agree. The chat breaking up about how do we find the time, and the question about the harm and the question about time. It is critical. It is critical that as leaders and as employees and as staff, that we look at how time is proportioned in our organizations, and that we actually see the investment in reflective practice as an investment in change. And reflective practice is that place where my origin story matters. And how I operate from my origin story then means, and I saw a comment about what about folks that come from a segregation past? Well, my origin story as somebody that comes from a segregation past is important because I'm leading or operating from that perspective. And there needs to be time to call me in and help me work on and change that as part of the organizational culture. So I don't think you were taking a risk by saying where the investments are. The investments are in profit and they're not in reflective practice, and therefore culture change is threatened and potentially harmful until we shift that investment. I couldn't agree more.
Thank you, Ken. And I think it's, what does feel provocative about the statement is, in the lunchroom, in the private conversations, people imply that this organization doesn't value us, right? But the honesty of saying, this is where we are. We are not valuing humans over profit. And I think we often are not at a place where we can name that very explicitly and the price of that and what will happen to the organization. We're literally at a shortage of workers right now. So I think it does start with that point of naming very explicitly.
Can I say one quick thing before I ask question 3? Is that okay? Do I have time for that?
You can ask no questions. I think you're allowed.
I was thinking, there is, Danica, I think in your micro thing, I wanted something about micro because there is something all of us can do. Reflective practice really comes down to 3 things. It comes down to connection, that we need to embed and embody connection in everything we do. Every email, every tweet, every text, every conversation, every rounds, every meeting. We need to connect. Just like Dana, you did so beautifully connect at the beginning with us around the mindful minute. That was connected. You can ask people how they're holding up because we are unwell. We are collectively unwell. We are grieving, we are rageful, we're exhausted and depleted. And asking the question is not dangerous. It's helpful. I can connect with you by asking you how you're holding up. The second thing is about coherence because we need to understand that it's really chaotic. And just the process, in the last 2 years, more people have said to me, am I making sense? Really smart people. And what I've said to them is yes. And their shoulders just go like, whew, because trauma and this is very chaotic. and helping people create a story that makes sense, that's coherent. And the third thing you've been talking about is collaboration. And collaboration is inclusion, and collaboration is difficult conversations. Collaboration is not, all la-di-da, everything's good. Collaboration is getting into really complicated, difficult, messy conversations that are going to move us in the right direction. And we can embed all three of those into our meetings, into our supervision, into all of our practices. And by doing that, we build reflective practice into the very core of our interactions, which is just good relational healing. And I want to say that, and I have a question to ask you, Danica. But it's over here. Okay. So then I go, what strategies and leverage, we've had this conversation, and so we wanted to get a little bit more specific. Like what strategies and levers can both health systems and individual providers use to influence and improve culture and provider culture, particularly as it pertains to understanding the impact of racism on health disparities and outcomes?
So Ken, I think you actually got me started a little bit because I was thinking about the micro, right? Because for me, and I think for a lot of people as well, the concept of culture change is so huge and so big, and people want to take it down to something that feels like bite-sized. So for me, in terms of the strategies and levers health systems or individual providers can use, I think it's very important to get a better understanding first of what is within, as you were saying, within your sphere of influence. So as an individual provider seeing dozens of patients a day, you are very much subject to the same systems that disempower your patients. And I say that as someone who is a medical social worker. So I've been inpatient, I've been on the floor. I know what that's like. And so the questions you can be asking yourselves are, what can you do in your interactions that lead to a more just, equitable experience for your patients? Are there ways in which you can challenge your personal biases? Do you even know what your personal biases are and how they impact how you hear and digest patient stories and develop treatment plans? Are you talking to your colleagues or your peers about your journey in this space? Or are you just saying, I treat all my patients the same, and that's just that? And at an organizational level, and CHCS talks about this actually in a little bit more detail in our brief, which is titled Integrating Racial Equity into Trauma-Informed Care. Maybe someone from our tech team can drop that in the chat so you all can see it. But it's also about getting commitment from leadership, and it's about doing something following that. Again, we're talking about centuries of trauma, mistrust, and hurt. So what's some low-hanging fruit that you can do? What's an easy thing that your community has been asking for that you can do right away? And you can say, see, look, this is proof of concept. Because people aren't going to trust you until you give them a reason to trust you. So you do have to do something. Wondering if you had any thoughts on that, Dana.
I do, but I see we're getting our time warning. I look, hello. I have lots of thoughts on it, but I do think that critical piece about trustworthiness is really, really an important one. And the other thing that I've been, just sitting with lately is how much conversations around trauma are in the space of intergenerational trauma, the ways that how trauma is passed on when there is a major injury. But I don't feel like there are enough conversations about what does it mean to have generations that have done harm and what trauma that does, like how one has to dissociate when those things occur, what price it costs to be part of systems that dehumanize people. And how that gets replicated because of trauma. So I think, in the trauma conversation, really integrating both of those who have survived trauma, but also those who have been a witness to groups of people being traumatized and what impact that has. But I'll leave it at that point.
Yes, I am the timekeeper, and I'm going to bring you to the Q&A. But before, I just wanted to thank you all. I was like cheering. I saw the amens in the chat. It's like get on your chair and clap. You guys were amazing, and thank you so much for gracing us with your knowledge and expertise. We really appreciate it. But there are a lot of questions to answer, and so I want to get into it. The first one, I know we have talked about it kind of adjacent to almost all of your comments, but what are some ways to think about accountability? Like, how do you hold people or systems accountable to this work, especially as it relates to some of the work that we're doing in the project related to oncology care and outcomes too? Like, how do you think about it and how do you measure it? And I'll open it up to the full group. Dr. oh, okay, good. Go ahead, Dr. Epstein. I see you come off mute first.
We were having a little battle of silence.
I saw that. I saw that.
Because I know my colleagues can answer this question, so I'll be brief. I want to say that trauma. One thing is shifting our perspective to understand that trauma and inequities are embedded at the organizational level. And we have to stop blaming people for what's happened to them and start asking organizations what's going on in the organization. And so you see symptoms organizationally of numbing and vicarious trauma, burnout. And it's time for us to stop saying, well, here's an app, or do some self-care for your problem, and start saying, how are we as an organization inducing it? I mean, the fact that we're down 50% of our nurses and our doctors and the symptoms we're seeing in our workforce, how unwell our workforce is, accountability is at the leadership level to address and understand that that's been induced by the organizations and didn't happen from COVID. It actually broke from COVID, but it was happening before. So the first thing I wanted to say is engaging leadership is really important, which is what we do a lot. We sit with leadership, talk with leadership, reflect with leadership, but engaging leadership to adopt and adapt and align this model with their strategic plans and with their work. So that's the first level of accountability. It's not the only level, because change doesn't happen from the top down. It happens from the bottom up or middle. We don't change because the leaders all of a sudden get some light bulb and say, hey, I've been doing it screwed up for all this time. But it does involve the leaders actually committing themselves to this process and working on leadership commitment. So I wanted to start there, and using then implementation science, really using implementation science to then build changes into the culture.
Yeah, I really appreciate that point, Ken. And I want to just amplify, because I think a lot of people have answered the accountability question in a lot of different spaces. But one of the things that I want to invite you to just reflect on, over the last few years, I've heard the call for accountability more than I have at any other point in my career. And when I hear the question of what does accountability look like, it sounds like, I don't trust you to do what you said you're going to do. That's what I hear in that. Like, how are you going to be accountable when you get it wrong? And so I invite, us to explore the call for accountability, why that is happening. To your point, Ken, what has happened in the organization that there needs to be accountability before people are even willing to engage in systems of change. And so, I don't know, there are many different ways I think you can hold people accountable through SMART goals, implementation science, and all of those things. But I do invite us very critically to ask the question about, what is the call for accountability coming from? What is that voice? And I think it is often anchored in a lot of historical trauma that has to be impacted and implemented within that system as well, and explored through time, again, back to time, and resources for reflection.
Can I answer? So, I mean, I don't know that I have anything to add on top of Dr. Epstein or Dr. Crawford, but, being a behavioral health person, part of me wants to say that, or part of me wants to acknowledge that accountability has to happen. Like, at the point we are at in the system, in terms of, like, Dr. Epstein talking about, not having the amount of nurses that we used to have, the system is on the brink of collapse. It's going to have to happen. So, like, kind of my question for systems and people who lead systems is, at what point is it going to become too painful for you to not hold yourself accountable? Because that, for me, just from a behavioral health standpoint, that's when people really start to change. When they're like, I can't keep doing what I was doing before because it's costing me too much.
Just to quickly add, there are models out there. I mean, talk about resistant leadership. There are models out there that I think it's a matter of supporting. It's a matter of the work being supported.
Thanks all. So in my next question, I'm going to combine some of the questions, and Dr. Crawford, I might ask you to respond first just because I know that you have specific thoughts on this. But there's a lot of questions coming up on trauma-informed care. And specifically, how do you bring up these conversations in the work setting, but also what are the cautions to bring up in the work setting regarding trauma-informed care? So I open up to the panelists, but Dr. Crawford, if you can respond first, I'd appreciate it.
Yeah, thank you for that question. And, I'm going to engage in a bit of strategic vulnerability and just kind of share my heart. So before COVID, I was trauma-informed enthusiast, and then COVID happened, and trauma-informed care didn't feel like it saved us from the heartbreak of working in a pandemic in a healthcare system. And that hurt is still really there. And I think in some ways, how realistic of an expectation to think that a system of thought of change would save us from a pandemic, but, I'm an idealist of sorts. And so, even before COVID, I had thoughts about trauma-informed care being very patient-oriented. And I think that is important. But the biggest caution that I offer now for any system that is even attempting to engage in becoming trauma-informed care, trauma-informed or trauma-informed system, is to acknowledge the hurt of your staff first and foremost. It is very hard to talk about thinking about what happened to a patient, what's happening within a system, when you are heartbroken, when you feel betrayed with how your system allotted resources when the pandemic happened, and who got to stay home and who did not, and when that happened and how it was communicated and how power was taken away and what family members died and how your children were exposed. And if none of that is a place of starting, then saying we're going to screen for our ACEs and trauma in our patients, and we want you to do that in a humane way, becomes really challenging and really painful. And I think for many people, it feels quite condescending and dismissive of their hurt. And so my biggest caution is, please don't start with the patient-oriented way. Start with your staff. Start with your team.
I've ditto, Dana. I know we've talked about this. I think a couple of things I've stopped using. I don't use the word trauma-informed care and haven't used it in years because I think it's easy to assign trauma-informed care, and then I start hearing somebody say to somebody else, well, that wasn't trauma-informed. It becomes actually an accusation, which is actually the opposite of what it's supposed to mean. Like anything, it becomes popularized, and then people say, well, you're not doing it, and then you get disciplined around it. And I think it then puts too much energy on the provider. I think the goal is really to see ourselves as healing organizations and apply measurements about what we would see as a healing organization, that we're flexible, that we're humane, that actually begin to measure that. And when we begin to measure how we help people around their hurt, then I think we're moving in the direction that we need to move. I think there's a danger. There's no danger in being trauma-informed, but that's basically the train and pray method. That's like, we're going to train everybody in being trauma-informed, and then we're going to pray their behavior is different. I think when you move the marker up and say that our healing organizations need to be healing for the staff that exists within them and the community, then you raise the bar on our expectations. And it can be done.
This next question, I might direct at you, Ken, first, and then if other panelists would like to also respond. But There's a lot of questions about how do you engage leadership in this work around acknowledging and addressing bias and racism in the healthcare systems, especially leadership that are often resistant to these changes, both for emotional reasons, financial reasons. But where and how should leadership be engaged? And how do you engage them when there is resistance?
I'm going to be humble and, and say, not everybody's engageable. So I'm going to start by saying, I'm going to answer the question and I'm going to say there are resistant leaders or we wouldn't be where we are. I mean, if we all had this idea, we wouldn't be having this conversation and we wouldn't be 400 years into, the ways in which this country and we've been. So I have to be humble. If our leaders were able to change this, they would have changed it. So I have to start by saying that in answer to the question. My optimism comes from that everybody has a story. And just like we started here with our disclosures, I have found that I've sat with leadership teams that the leadership teams have their stories of why they're doing the work, how they came into the work, and their own stories of trouble or trauma or why they've come into the system. And when they feel connected to each other and to the work, we can engage folks further. So conversations have to start with their mission, their vision, where they see the agency going, why they got into the work, and spending the time to understand and listen to the leadership, and then offering them alternatives. Like every leader has a strategic plan, and the part of their strategic plan that's not working is the one we're talking about. I mean, they might be making profits, that part's working. They might be increasing productivity, that part's working. But the part that's not working is the sociocultural change they need to make in their organization over and over again. We know that, after COVID, the people that were laid off first were DEI people in many of our organizations. And so, and then when George Floyd happened, the organizations went looking for those DEI people that they laid off. So there's a sense of getting before it and saying, if we really want to invest in this, really giving them a model. And I think we have a model. It's not culture change in organizations. There are models to do that. It has to do with training. It has to do with building champions. It has to do with having learning communities. I mean, there's a whole set of models all relying on the same principles and practices. And so engaging them in the hope that they can both do their jobs as leaders and the kinds of stressors they're under, and that they can invest in culture change by empowering their staff and the resources they have. I know that, I worked in a really impacted department of public health in San Francisco, and we had a leader that was invested in this change. And she helped us be the architect of trauma-informed systems. And I always have to say, Barbara Garcia had the vision that she needed to do this work, and at the same time, she needed to change the culture of the organization. And it is still a trauma-impacted organization, but there are 5 full-time staff working on trauma-informed and racial equity embedded in the organization, and that's their job. And to that, she invested in the change. And then I think leaders see that when they see it can lower their complaints to HR. They can build, less sick time, there'll be less sick time and time off. I mean, there are concrete results you can have from well staff, and there are concrete challenges when you have unwell staff. And so really appealing to those parts of leadership, first engaging them in their mission and then engaging them in the possible changes.
Thank you. I cannot believe this, but the hour is almost done. So I really appreciate you all sharing your expertise and wisdom, and offering us a space to reflect, to think, to understand, and to explore. So really appreciate you all and the grace and kind of wisdom you've all really shared with us. So as part of our practice and modeling of reflecting, we ask our participants another chat question. How are you feeling? How are you feeling after this very thought-provoking, really interesting, and intentional conversation. And so some of what I'm thinking is that we need time. We need time, we need space, we need leadership buy-in and engagement, and all of that is hard to attain, but is needed to really move the work forward. Change needs to happen from the inside and the outside, and needs to go through connection, relationships, and people. People are the power here. And so really thank you again to the panelists for really sharing your wisdom and your expertise. We hope to continue this conversation through our project, but also through our work at CHCS. If you go to the next slide, just some resources on kind of what we're trying to do and accomplish through this project and through some of our work. If you all want to take a minute to look at it. And then next slide and final slide. These are just some of the contact information for myself and Danica. If anyone has any questions about the content, the project, or would just like to connect with us in any way. And we have 3 minutes left. And I don't know if, again, to model, if Danica, Dr. Crawford, Dr. Epstein, any closing reflections from you all as we close the webinar. Danica, anything you want to start with?
I don't want to have like a doorknob handle moment. If you work in behavioral health, you know what that is. It's like you say something insane and then you walk out the door. So I will just say thank you so much for everyone who came to this webinar, to Dr. Crawford, to Dr. Epstein, to Dr. Patel, that's Shilpa. We have such a wonderful team that has been so open to asking these questions, and I could not ask for a better group of people to work with.
I could be quick. I can't see the 195 people on the screen, but I just want to express my gratitude. I can only imagine what you do every day. And I just have enormous gratitude and respect and humility for the work you do.
And I'll close with, I think that self-care in these days and these times are actually a revolutionary act, is activism. And so I invite you to think about how you can care for yourself, for your community, how you can listen to yourself, how you can listen to each other better. And just a reminder, it's usually not that important. Whatever that thing is that makes you not give that minute to yourself and to others, take the minute. It's worth it.
Thanks, Dr. Crawford. And you know what, with that, I'm going to give people the minute back. So take the minute and try to reflect and hopefully think about what was shared today and how it can apply to your work and the work moving forward. So really appreciate you all joining. And again, huge thank yous to our panelists on such an amazing webinar. Thank you so much.